pregnant patient is likely walking down the supplement aisle of your pharmacy or, sitting in your clinic waiting room scrolling through wellness blogs.
Right. Looking for the ultimate insurance policy.
Exactly. They're looking for that insurance policy for their baby's development. They just want to grab a prenatal vitamin, check the box, and kind of feel covered.
Yeah, but what if the supplement they ultimately choose is entirely missing the one specific nutrient linked to a twofold increase in the risk of neural tube defects?
Or what if their perfectly healthy morning routine, like a bowl of yogurt or a latte, is actually actively blocking the absorption of the critical minerals that did make it into that pill?
It happens all the time. I mean, the gap between the public perception of prenatal vitamins and the actual pharmacokinetic reality is just staggering.
It really is.
We treat these multiple micronutrient supplements, or MMNs, as these universal safety nets. But the clinical data paints a picture of a highly complex, fiercely regulated biological environment.
Right. The pregnant body is a master of physiological adaptation.
Exactly.
Yeah.
But we are frequently throwing the wrong raw materials at it, in the wrong formats, and honestly at the wrong times.
And that is the exact gap we are closing today. Welcome to this deep dive. We are talking directly to you, the pharmacists, the dietitians, and the healthcare providers who field these complex nutritional questions every single day.
Yeah, we are unpacking an authoritative medical text on nutrition in pregnancy today.
Right. Our mission is to look right past that generic, just take a prenatal advice and really equip you with the underlying pathophysiology.
Because we need to talk about why certain micronutrients require completely different dosing strategies, right? And the hidden dangers of wellness trends.
Yeah, and the actual mechanisms behind supplement efficacy. So let's ground this by looking at the default recommendation itself.
Yeah, let's do it. So the widespread push for routine MMNs actually stems from data generated in low and middle income countries. In those specific settings, where baseline dietary diversity is incredibly low and pre-existing micronutrient deficiency is high, prescribing a broad-spectrum MMN does modestly reduce the rates of low birth weight.
Right, and it reduces the risk of being born small for gestational age compared to just standard iron and folic acid.
Exactly. The intervention matches the systemic deficit perfectly.
But when you shift that clinical lens to high-income countries like the US or the UK, you're suddenly looking at a completely different baseline population.
Yeah, totally different baseline.
Yeah, and the evidence supporting a blanket MMN prescription for a well-nourished person essentially just evaporates.
It really does. And the contrast in international guidelines highlights this perfectly. I mean, in the UK, national health authorities do not recommend the routine prescription of MMNs for pregnant persons.
Wow, really? It's not recommended at all.
Right, not routinely. They advocate for targeted supplementation, specifically folic acid and vitamin D.
Oh, interesting.
Yeah, the rationale is that a well-nourished patient with a diverse diet is already meeting or even exceeding their daily requirements for most micronutrients through food alone.
Which completely changes how we should be counseling at the pharmacy counter in the US, right? Because the text emphasizes that MMNs here are actually indicated for targeted populations with inadequate diets.
Exactly. We're talking about strict vegans, adolescents, heavy smokers.
Patients carrying multiples or those who have undergone bariatric surgery, right? Where malabsorption is just a mechanical reality.
Right, because if you have a well-nourished patient taking a premium prenatal, U.S. data actually shows that up to 48% of them are exceeding the tolerable upper intake level for several micronutrients.
That's almost half of them.
Yeah, and pushing excess water-soluble vitamins simply creates, really expensive urine.
Yep.
But pushing excess fat-soluble vitamins or heavy metals, that introduces actual metabolic strain.
Okay, but there is one universal exception to this targeted approach, right? The undisputed champion of the supplement aisle, folate.
Oh, absolutely. Folate is the exception.
Folic acid supplementation and dietary fortification decrease the occurrence and recurrence of neural tube defects by at least 70%.
It's massive. That is population-level undeniable data.
Yeah. The recommended daily allowance is 0.6 milligrams, but the U.S. Preventive Services Task Force recommends a daily supplement of 0.4 to 0.8 milligrams starting a full month before conception.
Right. And continuing that specific supplementation past the first trimester is also biochemically necessary.
How so?
Well, the maternal system experiences a natural decline in serum folate as blood volume expands. And that decline can trigger a reciprocal rise in homocysteine concentrations.
Ah.
And elevated homocysteine is associated with poor vascular remodeling in the placenta. So maintaining that folate intake basically keeps homocysteine in check.
Okay, here is where I want to push on a specific counseling scenario because patients come to the counter armed with half-truths from social media all the time.
Constantly.
They will hold up a standard folic acid supplement in one hand and a much more expensive bottle labeled 5-MTHF, the quote-unquote active or methylated form of folate, in the other.
Yep, the MTHFR debate.
Exactly. They argue that because a percentage of the population has an MTHFR gene variant, standard folic acid is useless and they need the premium methylated version. As a clinician, how do we deconstruct that?
You have to separate a theoretical pharmacokinetic mechanism from hard clinical endpoints. It's crucial.
Okay, break that down for me.
So the 5-MTHF form does bypass the enzymatic conversion step that standard folic acid requires.
Yeah.
In a petri dish or when you're just measuring acute serum folate levels, it looks incredibly efficient.
Right, looks great on paper.
Exactly. However, in medicine, we do not prescribe based purely on surrogate markers. We prescribe based on clinical outcomes.
The actual results.
Yes. And the efficacy of 5-MTHF in actually reducing the physiological incidence of neural tube defects has never been evaluated in randomized controlled trials.
Wait, never.
Never. Standard folic acid, on the other hand, has decades of proven, massive population-level outcome data proving it prevents NTDs.
Even in populations with those MTHFR variants.
Yes, even in those populations.
That is a phenomenal distinction to make for patients. You aren't just paying for an active ingredient. You're trading a clinically proven outcome for an unproven hypothesis.
Exactly.
So if we establish that routine MMNs aren't a blanket necessity and that folate is the primary targeted requirement early on, let's look at how the maternal physiology physically restructures itself. I want to look at the skeletal system and blood volume, specifically calcium, vitamin D, and iron.
The biological engineering here is staggering, honestly. Fetal skeletal development requires the transfer of roughly 30 grams of calcium across the pregnancy.
30 grams?
Yeah, and the vast majority of that transfer happens incredibly rapidly in the third trimester. If the maternal body operated like a simple bank account, that sudden withdrawal would cause severe hypocalcemia.
But the maternal body acts as a proactive, highly strategic reserve, right? Instead of suddenly leaching it all from the maternal skeleton, the gastrointestinal tract undergoes a massive functional shift.
It does.
The text points out that maternal intestinal absorption and renal retention of calcium increase progressively throughout the entire gestation.
Yes. The body anticipates that third trimester demand and starts hoarding calcium literally on day one.
That's incredible. And that entire stockpiling mechanism relies entirely on vitamin D to maintain calcium homeostasis, right?
Exactly. The RDA is 600 IU, though the safe upper limit is conservatively set at 4,000 IU.
And the text also clarifies that D3-chlorcalciferol is the preferred form over D2, right?
Yeah, it's significantly more effective at maintaining serum 25-hydroxy vitamin D concentrations.
Okay, so this brings us to a massive physiological paradox. If the maternal GI tract is brilliant enough to progressively upregulate calcium absorption to meet fetal demand, why does it completely fail when it comes to iron?
The iron paradox.
Yeah. The text explicitly states that 10 to 53% of pregnant people are iron deficient. We know iron is the fundamental building block for expanding maternal red blood cell mass.
And driving fetal brain development.
Right. We also know that, theoretically, iron absorption increases as pregnancy advances. So why this systemic struggle?
The struggle lies in the inflammatory pathways and a tiny hepatic peptide hormone called hepcidin.
Hepcidin?
Yeah, hepcidin is essentially the master regulator of systemic iron. When hepcidin levels are high, it binds to and degrades ferroportin.
And ferroportin is?
It's the protein that transports iron out of the intestinal cells and into the bloodstream. If ferroportin is degraded, the iron you consume is trapped in the gut lining and eventually just excreted.
So hepcidin basically locks the gate.
Exactly, it locks the gate. Now, in a perfectly healthy pregnancy, hepcidin production is suppressed, opening those gates for maximum iron absorption.
Okay, so what's the catch?
There's a massive clinical caveat. Adipose tissue secretes inflammatory cytokines, specifically interleukin-6.
Oh, IL-6.
Yes, and IL-6 directly stimulates the liver to produce more hepcidin.
Wait, so in pregnant individuals who are overweight or obese?
That baseline systemic inflammation keeps hepcidin elevated, effectively blunting the physiological adaptation for iron absorption.
Wow. That completely changes the counseling dynamic.
Completely.
If systemic inflammation from a higher BMI is keeping hepcidin levels up and the iron transporter is locked, we cannot just blindly instruct a patient to swallow a heavier dose of daily iron.
No, absolutely not. We are just flooding a closed system and guaranteeing severe gastrointestinal distress.
And the dosing strategy itself often triggers the exact same trap.
Yes, the mucosal block.
Right. When a patient takes a massive daily dose of oral iron, it triggers an acute spike in hepcidin.
Exactly. And that spike essentially locks the intestinal doors for up to 48 hours.
It's like a bouncer at a nightclub. A massive crowd of iron shows up all at once, the bouncer panics, barricades the door, and just refuses to let anyone else in for the next 2 days.
That is the perfect analogy. So if that patient takes another heavy iron pill the very next morning, the door's still locked.
And the iron just sits in the GI tract.
Yep, causing nausea, constipation, black stools, completely destroying patient compliance.
Which is why the clinical data now points toward a vastly different approach. For preventing term anemia, intermittent iron supplementation dosing, just 1 to 3 times per week, or every other day, allows hepcidin levels to reset between doses.
Right. The evidence shows intermittent dosing is just as effective, or in some cases, even more effective than daily dosing.
Because the mucosal block is avoided.
Exactly. And crucially, the patient actually tolerates the regimen.
Right. But we also have to counsel on the dietary bullies, too.
Oh, the dietary blockers, yes.
Even if the hepcidin gates are open, non-heme iron, which is the form found in plant foods and all prenatal supplements, is highly vulnerable in the gut.
Very vulnerable.
The text highlights that non-heme iron absorption is aggressively inhibited by calcium and polyphenols.
So if a patient takes their intermittent iron supplement with a glass of milk, a morning latte, or a cup of tea,
The calcium and tannins bind the iron into insoluble complexes. It never even gets the chance to reach the transporter.
timing is absolutely everything. Iron requires an acidic, empty environment to thrive.
Okay, so if the body regulates iron so fiercely via hepcidin to protect blood volume, what happens to the specific raw materials required for the actual neurological hardware, the fetal brain?
That's where things get really concerning.
Because when you look at the standard prenatal label, the math on central nervous system development does not add up at all. Let's talk about the massive glaring gap in the supplement aisle, choline.
Choline is a fundamental component of acetylcholine, a vital neurotransmitter. It's also critical for sphingomyelin and phosphatidylcholine, which are essential for structural cell membranes and myelination of the fetal nervous system.
So it's incredibly important.
Vital. And the data indicates that low maternal choline intake is associated with a greater than 2-fold increase in the risk of neural tube defects, totally independent of folate levels.
Yet the daily required amount in the U.S. for a pregnant person is 450 milligrams, and U.S. dietary data shows that only 8.5% of pregnant individuals actually consume that amount.
It's a staggering population-level deficit.
It is. And when you flip over a standard premium prenatal vitamin and look at the choline content, it usually contains 0 or maybe 50 milligrams if you are lucky.
Wait, why is this supplement specifically designed for pregnancy missing a massive chunk of what's needed for brain development?
It comes down to the sheer physical chemistry of choline salts. They make it incredibly difficult to package.
Really?
To get 450 milligrams of choline into a multivitamin alongside calcium, iron, and everything else, the pill would basically be the size of a golf ball.
Oh, wow.
Yeah, so manufacturers just leave it out to keep the pill visually appealing and easy to swallow.
Which means we are leaving a critical neurodevelopmental nutrient entirely up to chance.
Yes, this elevates dietary counseling from a nice-to-have to an absolute clinical mandate. The daily requirement is best met by whole foods, right? Specifically eggs, meats, poultry, seafood, and dairy.
Right. Plant sources like navy beans, broccoli, and spinach contain drastically lower amounts.
The clinical implication there is stark. Patients adhering to strict vegetarian or vegan diets are facing an extreme risk of choline deficiency.
Absolutely. Because the standard prenatal abandons them on this front, clinicians must specifically recommend standalone choline supplements for these populations to ensure adequate neurodevelopment.
Okay, and the text notes that vegetarian diets present a few other specific hurdles too, right?
Yeah, zinc, for instance.
Right. Zinc has a recommended dietary allowance of 11 to 12 milligrams. While whole grains and legumes are rich in zinc, they are also rich in phytates.
And those phytates act as chelators, binding to the zinc in the digestive tract and severely decreasing its bioavailability.
Interestingly, though, the text notes that routine zinc supplementation across the board did not show significant improvements in maternal or fetal outcomes in randomized trials.
True, but vitamin B12 is a much harder line.
Okay, let's talk about B12.
The average intake of B12 from food in the U.S. is more than double the RDA of 2.6 micrograms.
Well,
However, B12 is synthesized exclusively by microorganisms and is only found naturally in animal products.
so vegan individuals have no dietary workaround.
Exactly. They strictly require B12 supplementation to prevent irreversible neurological impacts on the fetus.
We also need to talk about a nutrient gap created entirely by modern culinary trends: iodine.
Oh, this one is frustrating.
Iodine is the non-negotiable raw material for the production of maternal and fetal thyroid hormones. The RDA during pregnancy jumps to 220 micrograms.
Right?
For decades, prenatal vitamins didn't even bother including iodine because the requirement was effortlessly met through fortified table salt.
But the public health landscape shifted. The text highlights a concerning decline in iodine intake, directly correlated with the rise of artisanal sea salt, Himalayan pink salt, and the consumption of processed foods.
Because processed foods almost exclusively use non-iodized salt in manufacturing.
Exactly. We now have up to 56% of pregnant people in the U.S. exhibiting intakes below recommended levels.
It is the ultimate unforced error in modern nutrition. We don't want to encourage patients to suddenly start heavily salting their meals if they don't already, but for patients who cook at home, the counseling point is incredibly simple.
Just swipe the fancy salt.
Exactly. Tell them to swap the fancy, expensive sea salt for standard, cheap, iodized table salt. It is an immediate, highly effective clinical win that bypasses the supplement aisle entirely.
And that's key. Because when we identify these massive dietary gaps like choline or iodine, the natural instinct for a highly motivated, anxious patient is to try and out-supplement the problem.
Oh, for sure. They assume if one prenatal is good, two prenatals plus a greens powder plus a wellness shot must be better.
And this is where clinicians must aggressively screen for toxicity.
That more is better mindset is incredibly dangerous, particularly regarding vitamin A.
Very dangerous.
Vitamin A is crucial for cell division, fetal organogenesis, and vision. But the source and chemical structure of that vitamin A dictate whether it is a nutrient or a teratogen.
Yes. We have provitamin A carotenoids, like beta-carotene found in carrots, which the body converts to active vitamin A only as needed. That form is safe.
Okay. But the danger lies in preformed vitamin A, specifically retinol and retinol esters.
Right. Embryonic development relies on highly precise, localized concentration gradients of retinoic acid to signal cellular differentiation.
Okay.
When a patient floods their system with high doses of preformed vitamin A, anything greater than 10,000 international units per day, it obliterates those delicate gradients.
So the cells lose their geographic signaling.
Exactly, leading to severe congenital anomalies, particularly the central nervous system and cardiovascular structures.
The text establishes a hard boundary here. Pregnant people must avoid multivitamin or prenatal supplements containing more than 5,000 IU of preformed vitamin A.
And here is the hidden trap for pharmacists during medication reconciliation.
What's that?
Patients will often stop their prescription acne medications knowing they are teratogenic, but then they replace them with over-the-counter or online clear skin wellness supplements.
Oh, no.
Yeah, and those unregulated supplements frequently pack over 10,000 IU of preformed vitamin A. The patient is unwittingly subjecting the fetus to the exact same teratogenic mechanism they were trying to avoid.
That's terrifying. And this toxicity risk extends to natural superfoods as well, right? Liver is nature's storage depot for preformed vitamin A.
And the concentrations are wildly unpredictable.
The variance in the source material is crazy. The text notes that one cooked chicken liver contains roughly 3,980 IU of vitamin A, but just 3 ounces of raw New Zealand lamb liver contains a massive 78,600 IU.
It's unbelievable.
Eating liver during pregnancy is basically playing Russian roulette with a charcuterie board. Depending on the animal's diet and species, a single serving of liver pate could deliver 8 times the teratogenic threshold.
Right. Because of that sheer unpredictability, health authorities in several countries, including the UK and Finland, have issued blanket recommendations to avoid liver consumption entirely during pregnancy.
Makes sense.
In high-income countries where baseline vitamin A deficiency is extraordinarily rare, the prudent clinical advice is to severely limit or eliminate liver intake, particularly during that highly vulnerable first trimester.
We also have to monitor for iodine excess. We just established the danger of deficiency, but hyperdosing exceeding 1,100 micrograms daily has its own severe consequences.
Yes, the fetal thyroid gland does not have the regulatory escape mechanisms of an adult gland.
So massive doses of iodine cross the placenta and paradoxically block fetal thyroid hormone synthesis, causing a massive fetal goiter that can actually obstruct the fetal airway.
It's very serious. The text cites cases of congenital hypothyroidism linked directly to excessive nutritional supplements, or diets heavily reliant on massive quantities of kombu and concentrated seaweeds.
It is a delicate endocrine balance. And while we are monitoring dietary intake, the text makes a definitive ruling on processed trans fatty acids, or TFAs. They must be universally avoided.
Universally.
TFAs actively interfere with essential fatty acid metabolism. They competitively inhibit the desaturase enzymes that the body uses to convert healthy fats into arachidonic acid and DHA.
Which are the primary structural fats for the fetal brain.
Right. The FDA banned them in 2018, and the WHO is actively pursuing a global elimination target, but they still lurk in imported shelf-stable baked goods and certain margarines. Patients really must read labels.
So we have mapped out the validated requirements, the hepcidin hurdles, the structural gaps, and the toxic thresholds. But clinical practice inevitably collides with social media marketing.
Exactly. I want to shift our focus to the pharmacy counter realities. We're seeing a massive trend where patients attempt to biohack systemic metabolic conditions, like gestational diabetes or preeclampsia, by using heavily marketed isolated supplements.
It's everywhere.
Let's evaluate the clinical reality of these trendy interventions. Let's start with probiotics. The pitch is that optimizing the maternal gut microbiome will systematically reduce inflammatory obstetric events.
The mechanistic theory is appealing, for sure, but the clinical reality is deeply inconclusive.
Right.
There was significant initial hype based on small studies. However, when you look at subsequent highly robust meta-analyses, the data definitively does not support a reduction in the risk of gestational diabetes, preeclampsia, or preterm birth.
The systemic metabolic momentum of a pregnancy simply cannot be reversed by a daily probiotic capsule.
No, it can't.
Yeah.
There is limited data suggesting maternal supplementation might modestly decrease infantile colic in breastfed infants months later, but for major obstetric outcomes, the evidence just fails to materialize.
The exact same pattern applies to myo-inositol. This is arguably the most fiercely debated supplement in the PCOS and fertility communities. Patients take it hoping to regulate insulin signaling and prevent gestational diabetes.
And again, the early data offered a lot of hope. An early meta-analysis suggested myo-inositol could significantly reduce the incidence of gestational diabetes and preterm birth.
But science requires replication.
Exactly. A subsequent, much better designed, randomized controlled trial involving over 450 pregnant patients with PCOS was conducted.
And the result?
Absolutely zero statistical difference between the myo-inositol group and the placebo group for those major outcomes. While research continues, its clinical utility is currently highly uncertain. We really cannot confidently recommend it as a preventative tool.
Let's look at vitamin B6. Patients frequently ask if they need high doses for general fetal wellness.
Well, we have excellent validated data for vitamin B6 as a targeted intervention for mild to moderate nausea and vomiting in early pregnancy.
Right, the frontline recommendation.
Exactly. It's frontline for that specific symptom. However, beyond symptom management, a 2015 systematic review demonstrated no other clinical benefits for fetal or maternal outcomes. Standard dietary intake covers the baseline requirements effortlessly.
What about the heavy antioxidants, like vitamin C and E?
Routine supplementation of vitamin C or E across a general population has shown absolutely no benefit for preventing major complications like stillbirth, preterm birth, or preeclampsia.
Oh.
In fact, isolated high-dose antioxidants can sometimes act as pro-oxidants in certain environments. However, the text does highlight one fascinating, highly specific niche finding regarding harm reduction.
Yes, this is a phenomenal counseling pearl. In pregnant patients who actively smoke, there is evidence that targeted vitamin C supplementation might mitigate some of the specific oxidative damage caused by tobacco chemicals.
It's really interesting.
The data suggests it can modestly improve airway function and decrease the incidence of wheezing in the offspring. It does not erase the massive harms of smoking, obviously, but as a harm reduction strategy for a patient struggling to quit, it is a rare instance where an isolated vitamin offers a targeted mechanical defense.
It beautifully illustrates the fundamental principle of clinical nutrition. Context dictates efficacy.
That is the perfect framework for a pharmacist or dietitian to adopt. When a patient brings a trendy, heavily marketed bottle to your counter, you have to transition them from a mindset of generic biohacking to a mindset of targeted necessity.
Exactly. Prenatal nutrition is not a passive, one-size-fits-all insurance policy. It requires active clinical management.
It is about actively checking the label for choline because the manufacturing process almost guarantees it was left out, leaving the fetal nervous system vulnerable.
Right.
It is about screening their skincare routine for hidden teratogenic preformed vitamin A that could disrupt embryonic signaling. And it is about understanding the mucosal block and advising a patient to take their iron every other day with a glass of orange juice instead of their morning latte to outsmart the hepcidin surge.
It is about evaluating the physiological machinery in front of you and providing the specific raw materials it actually needs to function.
And before we close, I want to leave you with one final, deeply thought-provoking concept from the source material regarding just how complex that physiological machinery really is.
This part is fascinating.
We spent a significant amount of time detailing how fiercely the body regulates iron via hepcidin, and how iron deficiency is the single most prevalent nutrient deficiency worldwide. But looking at it purely as a mechanical failure ignores evolutionary biology.
Yep.
The text notes a fascinating phenomenon. In certain parts of the world, iron deficiency may actually exist as a protective evolutionary adaptation against malaria infection.
Yeah, because the malaria parasite, Plasmodium, requires massive amounts of host iron to replicate rapidly within the red blood cells. By maintaining a state of mild iron deficiency, the human host essentially starves the parasite, slowing the infection and increasing the chances of survival.
It is a profound biological trade-off. It is so significant that the World Health Organization literally mandates that in malaria endemic areas, supplemental iron can only be distributed in